Welcome back to another edition of the Hart2Heart Podcast, and my guest today is MD Amy West. Amy is an assistant professor of physical medicine, rehabilitation, and orthopedics at Zucker School of Medicine. Amy, welcome to the show.
Thanks so much for having me. It's great to be here.
So there's a lot of different reasons why I want to chat with you today. I've been following you on Instagram for a little while. I know that you're a physiatrist, which we'll get into in a little bit, but you're also majorly into CrossFit and fitness and nutrition and basically everything related to optimized health as far as I can tell.
Yeah.
But before we get into that, can you just tell everyone a little bit of a brief background about yourself?
So I am a physiatrist, a doctor of physical medicine and rehabilitation. So what that is we are a very small field in medicine. A lot of people don't know we exist, but we are doctors that focus on, MDs who focus on the physical manifestations of disease processes on the body. So what that means is how disease and treatments of disease affect the body physically and how they affect function. So we are essentially doctors of function, and we try to basically optimize people's function in their daily lives. So we deal with injuries that are permanent, like traumatic brain injuries and spinal cord injuries, and the medical management around those things, as well as more temporary injuries like sports injuries. And that's my subspecialty. I work essentially in orthopedics. I'm kind of like an orthopedic surgeon that doesn't do surgeries. So I treat all kinds of injuries non-operatively. My background is I was a television producer actually for a period of time in my life before I gave that up and went into medicine and did all my training at Harvard Medical School, did an education degree while I was there as well, followed by residency in physical medicine rehabilitation at Spalding Rehab Hospital, which is part of the Harvard system. And then after that, a sports medicine fellowship. And now I work for the Zucker School of Medicine in New York. I'm also a physician for Hofstra University for their athletics department, as well as other sporting events like the CrossFit Games and things like that.
So how many years of schooling was that in total?
God, at least looking something like 12 or something like that. Yeah. So the career change and the residency and the fellowships and the extra degrees and things. So I've been in school over a long time. I just finished so not that long ago. So I'm happy to be done with that. Yeah.
It takes a long time to become a physiatrist. Mm-hmm. So you mentioned there too, you do some treatments, but they're non-surgical treatments. So like what type of non-surgical treatments would a physiatrist do? Yeah.
So pretty much, I tell people think any kind of aches and pains or injury that you get, what you would normally see an orthopedic surgeon for. A lot of those things end up not needing surgery. So that's we would treat things the same way. So there's first, things like injections, and there's different kinds of injections, cortisone injections, hyaluronic acid injections, PRP, things like that, orthobiologics. Then there's, we refer people to physical therapists a fair amount. So we don't do the physical therapy. We help refer and help plan out some of the physical therapy. And then there's other things that affect musculoskeletal health, which is something that I focus on, and looking at also the metabolic picture of someone who has any kind of ache, pain, arthritis, things like that. Looking at the underlying metabolic hormonal kind of profile. What does that look like? How are they moving? Addressing movement dysfunction. With the ultimate goal of getting people back to, what they love doing.
So I really want to hone in a little bit on the injection part that you said. So corticosteroid injections, I've actually had a corticosteroid injection myself. It was very, very successful for my back. It's been amazing. But PRP is, something that I've looked into before, and I have seen some studies that have shown that some patients that did PRP versus cortisone alone actually did do better at, say, like 6 and 12 months, something like that. I don't know the exact authors of the study, but I have seen some studies like that. And then there's these new treatments that are coming out now, stem cells, exosomes, and all these things. So is there like a sequential order that you always use, or would it depend upon the nature of the injury?
It depends. So, with a lot of the things like stem cells, lipogen, which is fat cells that are used, as well as things like PRP, those aren't covered by insurance. So, I work in a big health system, so the out-of-pocket cost for some of those things can be over $1,000 per procedure. So, a lot of times it's just not an option for certain people. They just don't want to even try it because it's pretty cost prohibitive in some circumstances. But it depends on the age of the patient. It depends on what their goals are, what kind of activity level they have, what kind of injury. Is this a tendon injury? Is this a joint issue? The degree of injury, because there's certain things, big full thickness tears of a rotator cuff versus a partial thickness tear. An injection of PRP or a conservative non-operative treatment is more likely to work, and obviously smaller, less severe things. So
if you do have like a partial tear, can PRP completely heal that on its own?
I wouldn't say that. I mean, there's a lot of evidence that there's different studies that have shown some of these partial tearing, depending on where it is, the, full thickness, partial thickness, the degree of the tear, evidence of retraction, things like that can be improved. In some cases healed. In some cases, not so much. So I tend to err on the side of kind of reasonable expectations. I think it can make, these treatments in some cases can help with healing process. In a lot of cases, it also can help with pain and function around it. So even if the tear doesn't heal, when you do physical therapy and you're doing, and you're also helping induce some inflammation in the shoulder, that's helping to, bring inflammatory responses to that area to help with some of the pain, ultimately to help with some of the pain and healing. You can improve the function of the shoulder. Now, will the tear completely fix itself? Unclear. And I think in some cases it does. And there's been papers that have shown that. And in some cases it doesn't. So I think it's a lot of with these injections is managing expectations. And certainly with smaller, like lesser degree things, it has very good evidence and good use, reasonable use. Some of the more severe, bigger tears, or like anyone with like severe arthritis, these things, they don't work as well. So it's just understanding kind of what the injury is, how bad it is, and then also what kind of therapy goes hand in hand with it to optimize the outcome.
Say if you have a tear and you really want to get better, you're basically doing whatever it would take to get it better. Mm-hmm. So you do cortisone, it doesn't work too well. Mm-hmm. Then you get PRP, maybe that doesn't work too well. Would you then advise them to go for stem cells?
So like when you talk about like cortisone injections, like those don't heal anything. Those just cover pain for a period of time. So like with steroids, especially in younger people, I try to avoid them altogether because actually repetitive steroid use, cortisone steroid injections can actually degrade cartilage or cause further damage. So
and how many injections would you have to have before that happened?
Sometimes they see evidence of that after just a single one. I mean, but, a one-time thing to get someone over the hump of like severe pain so that they can facilitate movement and physical therapy I'm all for that. But if someone comes back 3 months later, the medication lasts you about 3 months, it starts to wear off. I don't want to keep injecting someone every 3 months to get them through a younger person, especially because that will probably lead to further tendon injury and ultimately rupture potentially.
Does that mean that sometimes you would use PRP then ahead of cortisone?
So yeah. So, I mean, and cortisone injections, I don't love in younger people unless it's going to be like a one-time thing. And so the PRP kind of how it works is that it induces inflammation, which is like a healing response in the body. So if you actually put steroid in there before or very closely after that, you're kind of canceling out the effects of the PRP. So you wouldn't necessarily do both in close proximity to each other because they're sort of hindering each other. But, in certain cases in a younger person, I would likely opt to try some kind of orthobiologic first, depending on, what the goal is, and then the stem cell treatments, there are, that's sort of the next step up from that. Like I said, some of that's still, the technology is sort of changing on that a little bit, or it has changed a fair amount. So it's getting better, but it's kind of the outcomes from that there's evidence kind of in both directions.
Okay. Yeah. Cause I've heard people like Peter Attia said that, he doesn't really, I'm not sure if his mind has changed this, but I think a little while ago, he kind of said he didn't really notice any difference when he, he didn't see there was any good evidence for stem cells. But what he did use on himself, which was, I think BP157 for some kind of injury he had. And he said he didn't notice that much, but a lot of people
do find it to be effective. Again, it's really early stages. I think most of the trials on that are on very few people. So, kind of early stages on that. But there are people, again, like Joe Rogan says that he had a full tear and then he had stem cells, and now he has full function of his shoulder, and his tear is completely healed. So like there's people who have these, I think, miraculous, recoveries or responses, but I don't necessarily think that's like the norm overall. And I don't think there's, am I correct in saying like there's very few randomized control trials on stem cells?
There aren't many. I mean, there's certain groups like the Regenix group that has, that's kind of like their thing. That's what they do. So they have a lot of trials, sort of like their own internal data that they publish that are fairly convincing. I think also when we talk about like stem cells, for example, even PRP, there's not very good standardization of what a PRP injection consists of. It's all over the place as far as the concentration and the uses and how it's injected. Is it injected under any kind of ultrasound guidance? So like in physiatry, we're very big into musculoskeletal ultrasound to help guide procedures and make diagnoses. If you're injecting
does
something...
that mean that all PRP is not the same?
Yep.
Yeah. So I think that's the thing, important, right? for people to know, is that all PRP is not the same. But you're saying, Amy, that like, you're not just saying like, ultrasound guide is different than, non-ultrasound guide. You're saying the PRP itself is different. So the actual PRP, I mean, there's some machines, you just set a button and it like makes a certain concentration, but that's not even standardized across procedures, across machines, across different places have different ways of doing it. So that's something that actually there's been a kind of a movement towards standardizing that, or at least standardizing the studies. So this way you say, okay, this is the concentration. This is how many injections were done. This is how far apart they were done. This is how they were guided. This is where they were injected. I mean, all of that stuff are all factors. And also the type of injury too is very different. So Joe Rogan's rotator cuff tear, I don't know the specifics of it, may be very different than what someone else is dealing with. So then they say, well, it worked for him, but not for me, but their thing was different than his thing. And so there's a lot of confounding factors when we talk about these kind of procedures that it's hard to make like a blanket statement like, yes, it's good. No, it's not. But I think in the right person, under the right guidance, with the right concentration and the right protocol after, can have fairly good effects, but nothing is guaranteed. That's kind of my feeling about it. Yeah. And what they can do outside of the country and what they can do in the country are also different as far as the stem cells that are being used and how they process them and stuff. And it's different, again, like different things in different places. And so, it's all over the place. So why would people be going to places like Colombia? Like what can they do in Colombia that you can't do in New York? Well,
there's a way of manipulating the material and the amount of processing that can occur once it's extracted, once the bone marrow is extracted, and the kinds of stem cells that can be used. Basically in the States, it has to be able to minimally process before it can be injected back into somebody. There's all these rules about manipulating stem cells that in the Colombia, they don't have to worry about. So there's question of whether the stuff that they're using down there is a little more effective because they can manipulate it in a certain way that we can't. So that's also part of it too, is like you'll hear about like NBA players going to Europe or whatever to get these things done because it just can't, we're not allowed to do the same things here. So that's a whole other set of data that shows different, may show different results.
Okay. Interesting. So do you think that more of this stuff will become mainstream, or do you think that it's still in like the early stages and it's going to be a while before, people are going to be, the average person is going to be getting stem cell injections?
I mean, I think it's going to be a while. I mean, I think the key is really, the issue is insurance coverage for it. So I think in some health systems, I've heard of PRP being covered by insurance in certain cases, which then obviously that increases the, people wanting to do it because it's something to try. I always say if someone has for certain cases, if someone has the funds for it, it's worth trying. I think that's something that if more insurances are covering these procedures, then possibly also something we run into too is that there are clinics set up by people of unknown credentials saying, oh yeah, come and get these PRP injections, pay X amount out of pocket, we'll do 5 injections, and they promise all these things, and then who knows how it's put in and what the concentration. It's all a little bit shady. So then, people are quick to poo-poo the whole thing because they say, well, look at this, it's kind of a scam, But so it's again like responsible use of these things, like very honest discussions of what they can and can't do, managing expectations, and if done in the right setting, hopefully it's something that becomes an option that is available to more people. But as of right now, it's out of pocket cost. It's somewhat prohibitive.
Yeah, I can understand that. It's the prices I've seen for them have been, pretty sky high in Canada. Like some PRP people, I think were charging like $1,800 or almost $3,000 for an injection. So, a lot of people can't afford that, especially with the economy these days in Canada and the housing crisis we have here.
Yeah.
But just to kind of switch gears a little bit, I may come back to physiatry. Actually, before I actually my research, I do have one more question. Peptides. I did want to ask you a little bit about peptides. Do you think there's any evidence for those right now, or not so much?
Well, the evidence is again it's not well studied, and there's a lot of like anecdata about it being useful, and certainly mechanism wise makes sense. I know of people who've had very good results using them. Formal studies. This is sort of people doing self experimentation and things like that. It makes sense to me as far as how they work and the possibilities and sort of seemingly lower risk. Risks involved. So there's certainly there's a lot of opportunity, I think, there to do more exploration.
Yeah. Do you think, another question too on that, do you think there are any of these things that we talked about, do you think any of them should be on the WADA list? Just because, like, to me, they're just all healing agents. Like, they don't actually improve like performance per se, in my opinion anyway. But like, do you see them as like, do you think they should be on the WADA list? Any of the things we've talked about so far?
I mean, as far as like PRP and stem cells, things like that, no, because you're basically taking your body's own own stuff and putting it back in. So it doesn't really make a whole lot of sense to me. Like, that stuff would be seen as necessarily performance enhancing. I think some of the peptides, I think are kind of hard to test for. But like, there are some performance enhancing benefits, but again, it's a little.
No, you're right, because like BPC 157, I think would have 0 performance enhancing benefits, but then TB 500, which seems to be its paired cousin, that definitely has some performance enhancing benefits. Maybe not gigantic, but definitely a little bit. I think there's some growth hormone production that it increases, which would obviously aid with a lot of things.
So they're sort of downstream, but so I can see why those would be.
Yeah, that'll be interesting to see what happens, because a lot of people are obviously using these substances and, getting away with it, so we'll see what happens. But I just wanted to switch gears a little bit away from the physiatry. So I want to talk a little bit about nutrition and, more, I guess, the stuff that you do outside of work. You're massively into CrossFit, like we were talking about at the start of the show. It looks like you lift weights all the time. I've seen you pictures with like Dr. Sean Baker, who's kind of like the carnivore guy. If you guys don't know who he is, he was on Rogan just like 2 weeks ago, I think, something like that. So anyways, my question for you is regarding medicine. Like, a lot of people think that, if doctors had more education in nutrition, that would lead to better patient outcomes overall. I completely agree that we get terrible education on nutrition in medical school. First of all, there's very little of it. I mean, there may only be a few hours in the entire 4 years. I mean, I can't really remember the class I did on it, to be honest. And the information that we receive is very, very basic, meaning like it's more or less just based off like governmental food guides. And, more or less, if you know that food guide, then you would know, the basics of what you would learn in medical school. So how do you feel about nutritional education that we receive? And do you think that would affect patient outcomes?
Well, I mean, so ideally, yes. Ideally, if we learn more and we're able to effectively communicate those things, and had solid plans for those things, and patients wanted to hear those things, and we had time to communicate those things, then yes, then yes, that would help. But I think if, like you were saying, a lot of the education or the guidelines that are being set by governmental agencies or other things that are essentially influenced by the food industry, processed food industry and sugar industry, who have blatantly meddled in forming those guidelines. So, if that's the education that's being passed down to, medical schools, having more of that, I don't think is going to be very effective in changing anything, because those guidelines that have been in place have resulted in, at least in the United States, of just us getting fatter and sicker over the past 20 years. So educating people to regurgitate those guidelines to patients is not going to change anything. In fact, it's probably going to make things worse. Yes, I'm all for the nutrition education in medical schools and encouraging patients to eat well, but we have to have something to provide them with that actually results in better health outcomes, but then also have something that we can have focused and also like tools to provide people with, say, okay, well, you should eat better and this is what you should do. And now here's how you're going to do it. Because I think we're really good at giving recommendations, but then it's like, okay, well then go figure it out on your own, which no one really has the time for that either. So not to mention, our time in an appointment to go over someone's nutrition and really dive into it and understand where they're coming from takes a substantial amount of time, which, often we're not allowed to have.
No, I agree with you on all fronts. Like the food, pyramid. I mean, I don't follow that like at all. It's complete opposite of what I do in my life. I mean, I'm pretty. I just eat mostly protein in the day. So, like for example, like today, all I've really had is like a protein shake and then 4 or 5 eggs, a handful of almonds, and a Quest bar kind of thing. Which that is not like remotely close to what's being promoted on the food pyramid guide. So the food pyramid guide is heavily on carbs. And the big problem with it is there's almost no protein. And I forget what the exact protein recommendation is, but it's something like 0.3 like per pound of grams of protein per pound.
Enough to keep you alive, but
yeah, just barely enough to keep you alive. And like, you should be aiming, like a lot of people say this, I say it too, about 1 gram per pound. There are some, deeper profiles on that, recommendations out there. BioLane T or Lane Norton's gone into the form, but that's a really, really good basic rule, I think, for most people to follow. And that's not, followed at all. And then the other part of this too is that, I agree with you too. Like the time is, it's very, very difficult to, educate someone on nutrition quickly. It does take a lot of time, and, it takes a lot of time on their part and a lot of effort as well, and not everyone's going to be ready for that right away. So, that's another big issue. And then the other thing too, like we were kind of chatting about before the show, is like, it also does come down to the patient themselves. So like, we can certainly get more nutritional education, but I'm not 100% convinced that's definitely going to lead to better patient outcomes, because patients do have access to lots of nutrition and lots of things online where they can learn. Obviously, not everything online is what you want to read into, but there are lots of good resources. So I do kind of question whether or not the idea that like, if doctors knew more about nutrition, then the population would be healthier as a whole.
Yeah, it's like, well, who's telling them? It's the same thing with exercise guidelines too. I mean, the exercise guidelines that we have right now are flawed in many ways. And it's, I think so encouraging people to exercise more or eat well is a great idea. And yes, I think we all support that and ultimately want to see that happen. But the details of that are really where things start to fall apart. So And then there's also the element of like, if people don't want to do those things, they're not going to do them regardless of what you present to them. And I think, I talk to a lot of people in the fitness industry, and they see people who walk into a gym and they're like, these people are like, oh, if, the doctors aren't serving them because these people want to get healthy. And it's like, yeah, if someone's already made it into a gym, they're so far ahead of where they are when they walk into my office, because they've already realized that they have to change, they want to change, and they've taken action to do that. And they're in your gym. They're 10 steps ahead of where they are when they come to me. So half the time people are that they don't even want to take those steps. So they don't realize that there's a problem, So there's an element of that too. It's like people have to want to do it for themselves more than anything.
Yeah. Getting there is definitely, half the battle. But one thing I wanted to interject on there too, what you were saying, it was kind of seems like, you feel, and I certainly agree with you, that, we could have, different standards or different ideals, like not just with regard to nutrition, but also with regards to, like clinical parameters and like health parameters. So just for example, we take like, blood pressure, so technically like, 139/89 is, normal. It's not hypertensive, at least in Canada. It's got to be, 140/90. But, Peter Attia and a lot of other people are now saying, optimal really should be like 120/80 or 120/70. I've heard Andy Galpin, when he was on Andrew Huberman's podcast, like he was saying, if your pulse isn't under 70, then you're not fit. So like, what sort of like guidelines would you give people to be, if they wanted to live optimally, as opposed to just kind of, meet the standard guidelines?
Well, yeah, I think this is kind of what we certainly at CrossFit talk a lot about, is like the sickness, wellness, fitness continuum. So, in medicine and sort of how it's designed now is like, we're happy when people just aren't sick. So they're like in this middle space of being like, quote unquote, well, but they're just on the verge of sickness. They're not sick yet. Like your A1C is just outside the window of being diabetic. So good for you. Right. Whereas like what we aim to do is really move people towards fitness. So being, fit to the point that even if you do have some kind of hit, whether that's a physical issue or cancer or something, that it's not as severe. It doesn't knock you down as much and for as long, but that also you're more prepared, or if you catch some kind of virus, for example, that you're not completely devastated by it. You have that extra space that you start moving towards. If anything, you're moving towards wellness rather than total sickness. So, that's kind of idea with whether we're talking about with nutrition, for example, like we were saying, is like, yes, the protein recommendations are to keep you alive, to keep you out of that sick category, basically not dead, but that's not the place to live optimally. You want to be eating more protein such that your muscle mass, you're robust, rather than someone who's just not sick. And that goes along, same thing with things like A1C and blood pressure. You want to move those things. Yes, there's a guideline, and you want to be better than that. But ideally, you want to be moving even further from that, so such that you're actually physically fit rather than just well enough to not be in the hospital.
Yeah, I'm so glad you brought up A1C, because that's a big one for me. So for people who don't know what we're talking about, hemoglobin A1C, it's a blood test you can get. It's a fantastic test. It's a measurement of your blood sugar over 3 months, which is obviously much better than just getting one single snapshot. And in Canada, it's if you're greater than 6.5, you're diabetic. 6.0 to 6.4, you'd be pre-diabetic. And then impressively, they do have, like, even right on the blood work that I get back, they'll say 5.5 to 5.9 is at risk. So I always call patients back if their hemoglobin A1C is even above 5.4, because they're at risk of being diabetic, and like they should know that. And I think that, a lot of doctors will let that go till it's 5.9, sometimes, till it gets like 6.4, till they're not actually diabetic, till they are actually diabetic. But I think, that's a very, very good indicator. And like the other ones we've mentioned too, blood pressure and pulse, like just keeping track of like the real basics, I think can make a real big difference. And the other thing too is that when you do get objective measurements, and if you can lower them, it seems to motivate people quite a bit. So that's why I sort of like, telling people their numbers and then showing them progress, from one appointment to the next, because it seems to, increase motivation. But in terms of, hemoglobin A1C, like, is there a particular number that you like to see? Like, are you like, say if your hemoglobin A1C was 5.4, Amy, would you, make some changes and be like, I need to get it down to 5.1?
I think it's, if I saw a 5.4, I think that is it's like a flashing light. Like things are not going in the way you want them to go. So is it like emergency? Let's start medications and no. But what it is saying is like, there are some things here that need to be adjusted. So I think if I see that number, that's like, okay, we need to look at what you're eating. And a lot of times I think people aren't realizing how much sugar is in all the stuff that they're eating, even if they're not eating something that's sweet. Right. So, or, how much, look at the food, look at the exercise. I mean, it's an opportunity to open up the conversation, so that, because we're headed in the wrong direction. We're approaching the mountain, So, I mean, I've seen this debate too with like something like a CGM, like a continued glucose monitor. And people say, what's the utility of, using that if you're not diabetic? And I think part of it is just the awareness. So I think something like that, having that is just the awareness of, even if it's for a short period of time, saying, look at what's doing it to your body, not to keep it on forever, not to obsess about it, not to get crazy over every little thing you intake, but to have that objective data. Same thing with, there's a lot of things that, like, if you have the data, I think it opens people's eyes to like exactly where they are. And I think a lot of people have a very, misguided opinion of where they are health-wise until some data smacks them in the face. And I think that's an example of how that happens. I mean, same thing with things like, I'm a big fan of like either DEXA scans or in-body scans. And it kind of gives you a whole layout, body fat percentage, muscle mass, visceral fat, like getting those numbers, people are usually very surprised. Very surprised.
Visceral fat is a big one. Dr. Jamie Seaman, who was on the show pretty recently, she was, talked quite a bit about that, and she gets DEXA scans. I mean, I'm sure for other purposes, but I think primarily for that reason, just because you can be fairly lean or look fairly lean, but then have, visceral fat around your organs, which, unfortunately, is worse than having just regular fat.
Right. So, I mean, I think people, it's sometimes they don't have that number, they are surprised. So I usually for like yearly kind of check-ins, I recommend like a blood panel, some kind of DEXA scan or body composition scan. So there's in-body scans, which are not cheaper, no radiation, if that's sort of another way to go about it, if you don't have access to a DEXA scan. And then usually I recommend some kind of physical fitness test. For us in CrossFit, we do the CrossFit Open every year, and it kind of gives you some objective data of like what you can do and not do. But if there's a certain workout, a race, something that you do every year, so you can just see like physically where you are. And, if it's a lot harder this year than it was last year, or if your time is getting a lot worse, then you have to sort of look into why that is happening, if there's a reason for it. And I think that gives people a good assessment of where they are physically, which I think we kind of ignore sometimes. We just look at lab values, but it's like also how are you functioning in your life? How easy is it for you to do the things that you want to do? So I think it's another thing that's important.
Yeah, no, it's a very good point. Actually, I don't really do that, but I could incorporate more, questions as to like, how you're doing this year in terms of your mobility and that kind of thing, versus last year, as opposed to say, just looking at blood work. But on that note, just coming back to blood work for a sec, because I know that you talked about metabolic health earlier a little bit as well. So are there any specific blood tests that you order, particularly for lipids? Like I know it seems like right now, or as well, really always, lipids is a thing that gets debated the most. There's like, the LDL-C, which Peter Attia has really, gone crazy with in his longevity book and, getting it down. And there's a lot of people have jumped on there with them, like Lane Norton's like that as well. There's a couple other guys I think, are big LDL lowers. Peter's also really big into ordering ApoB. And then there's the NMR test, which, tests for your particle size. And then Peter's talked a lot about LP little a, which he believes now is, strongly linked. And then there's the oxidized LDL test some people are ordering now as well. And then the standard lipid panel, which always has your HDL and your triglycerides, seems to be getting a lot more attention now because people are paying attention to their triglyceride to HDL ratio for insulin resistance. Mm-hmm. So I know that was a little bit of a mouthful, but out of those tests, like which ones do you like? They're all important, but if you can kind of rank them, or which ones do you think that people should definitely get every year?
So certainly the sort of the standard lipid panel.
I agree 100%.
I think it's important to get look at things like ApoB and LP(a). As far as having a background, it's necessarily important to get frequently, but to have at least have some understanding of also how there's some genetic component of this as well that plays part in that, and that can also help give you some insight into that. I think also in the context of these is really to not look at it in isolation, look at it in relation to insulin resistance, because ultimately insulin resistance ends up playing a much larger part in how these levels affect you and how are also a sign of like your health at large. So looking at both of those things kind of in tandem rather than just like lipids over here, A1C over here, but looking also over like overall insulin resistance. So I think that's super important to look at. And then, as far as like LDL, LDLP, like looking at the breakdown, the particle size breakdown is super important to see the amount of the ratio of small to large particles. So I look at all of those. And then, I think there's been a lot of like controversy about which ones are more important. I think the data is kind of always a little bit kind of here and there as far as like what we should be changing. I think sort of the standard panel is adding those extra labs in there, but then also looking in the context of like other things that are going on with this person, and insulin resistance is a huge one that can't be ignored in this process, and optimizing both of those things. Because if you're just targeting the LDL and not targeting someone's insulin resistance, you're going to miss the boat. So I think if you target insulin resistance, both will follow. Whereas just focusing on one or the other, you kind of miss the bigger picture about this person's health.
And so what do you think is the ideal triglyceride to HDL ratio? Because that's the ratio for insulin resistance that a lot of people are talking about right now is triglycerides to HDL. Like, is there a specific ratio that you think is best that people should have?
I'm trying to remember the number that off the top of my head because
I think like they recommend like 2-to-1, but I mean that's easy. Like almost like most people have an HDL higher than their triglycerides. So like I think that it's like a woefully low bar. I think it should be the opposite. Like you should try to have, in my opinion, an HDL twice as high as your triglycerides. And
I think ultimately, again, like. Yeah, I mean, it's sort of like the standards that are on sort of traditional lab values tend to be kind of lowest common denominator. Like, again, like this, like not sick part. I think if we flip that, to get closer, we can get to flipping that is, moving people into that fitness space. So, ideally, kind of the closer we can get to that flip number, the better. So I would agree with that statement.
And I think too, like the more you raise the bar, then if people miss it, they miss it by less. So like if you say the HDL ratio, it should be, 2-to-1 in the other way, then if people miss it, maybe it's just like they're at 1-to-1. But then if you say, at 2-to-1 in the, triglyceride to HDL ratio like it is right now, which was a very low bar, and then someone misses it, and then they're like, oh, I'm only at 3-to-1, like it's not so bad. It's like, no, that's pretty, terrible. We need to make that change, So I think that, by setting higher bars, you can just kind of raise the population in general. So I like the idea of like, everyone try to get as fit as you possibly can, like, focus on it all the time. Because if you do that and you miss, well, you'll still probably be kind of fit, So I think we should raise some of the standards in medicine.
Yeah, I mean, certainly with exercise, that is something that recommending 150 minutes of walking a week. It's like, that's great if you never move, but you're fooling yourself if you think that's going to make you a fit person. And I think we have to sort of say that. And that's, because we're setting the bar of just like getting off of your couch as being fit, like, and that's great for someone who never moves. Yep. Get out and walk. That's great. But to say that that's the pinnacle for most people doesn't make a whole lot of sense. It's also, I mean, if it's a perfect example, if you look at like gym classes for kids, if you look at what those classes were in like the 1950s and the things that they were doing in gym classes, it's like peg boards and rope climbs and like, gymnastics, all this kind of crazy stuff. And now it's like kids doing wall push-ups and we're saying, good job, and it's like, if you set the bar low, that's what you're going to get. So, raising the standard for people is only going to improve their health.
Yeah, I completely agree. We haven't chatted too much about exercise as a treatment for, things yet. And obviously, the thing that I always tell all my patients who have any kind of, mental health problems is, exercise is definitely something you should be doing. It can be more effective than drugs. They've shown in studies it's, as effective or more effective than SSRIs or selective serotonin reuptake inhibitors, which are, common antidepressants. So, with your patients, I guess you must see a lot of patients who, are rehabilitating, but at the same time, they're exercising again. So with that exercise, do you find that, their overall mental health improves as well?
Yeah. So, I mean, exercise is a great way to improve mental health. And, I've actually spoken a fair amount of this with Chris Palmer, who, does a bunch of studies about, how like metabolic health affects mental health. And we've spoken about how metabolic health affects musculoskeletal health, and actually all of these things affect each other. So it's, the inflammatory cytokines that are in the body when someone is metabolically unhealthy as a result of excess adipose tissue affect all the tissues negatively, and including your brain, including your tendons, including your joints. So by exercising, the endorphin release and the positive benefits from the actual moving, the reduction in adipose tissue and the effects that has on the body. And then there's a whole social aspect of it, which I think is huge. Finding a fitness community, whatever that is for you, finding like other people who are there to support you, who are there to encourage good behavior, who are going to hold you accountable.
100%.
I mean, all of those things are huge in exercise as well, which I think we miss out on too, as far as just having that social support.
Yeah, you ask anyone who plays hockey, and they'll all say that they miss being in the dressing room as much as they miss being on the ice.
Yeah, exactly.
So there's a big social aspect to it, and I mean, I can just tell from your pictures on Instagram. Obviously, you hang out with a lot of like-minded people. You go to all these events, so there seems to be quite a bit of like social interaction in the CrossFit community in general, sort of.
Yeah, that's kind of the big thing that I think sets it apart in some ways, is that it really is a community. Every gym has its own unique kind of culture, but you find, I've met so many people through exercising in professional capacity, personal capacity. And, it ends up being almost like a church in a sense, that people kind of gather and talk about things and celebrate each other and stuff. So it's a really nice aspect that I think you can miss out on. And like, I played team sports my whole life. So when I finished that, I was kind of like, well, now what? I get on a treadmill, I guess. But like when I found CrossFit gym, I was like, oh, wow, this is great. And I feel like I'm part of a team again, which I missed.
Yeah. And a lot of people who do jiu-jitsu and martial arts and that, they feel the same way too. That's my thing now is, martial arts. And I love training and seeing my friends there. It does make a big difference.
Yeah.
One tough thing or tough question or tough thing for patients to go through is like, we all have patients who say that they're like too depressed to exercise. And like, in that case, like, it's very, very hard to say, other than like, you just have to summon up willpower. Like sometimes I tell patients if they can get into a sauna, is maybe, just the sweat will kind of make them feel like they're doing something. And there is, some
benefit cardiovascular wise, like very, very limited, but some in sitting in a sauna. But, in your, explorations with mental health and exercise, like what do you do when you come across someone who says, they're too depressed to exercise? And, I'm not expecting you to have the magical answer here, because this is something that, is a big topic of debate, and something that a lot of people are trying to figure out.
Yeah. I mean, it's certainly tough. And I think sometimes it's hard to work around, but I mean, part of it is instead of focusing on like the exercise portion of it, it's like, I talk in terms of function and talk for like goals. So it's like, what's something that you want to do that you're not doing right now, or something that you want to be able to do that you can't, and like, how do we get to that? So a lot of times with, it's if people want to like play with their kids, or they want to go walking around this place, right, or do, there's some kind of goal in mind of, even if it's sort of short term, like what's the thing that you want to do, especially when you're focusing on the weight loss. Cause I think if you focus on like weight, that people who have been tried to lose weight are kind of sick of hearing about that. But if it's like, what can you do with the weight loss that you're not doing now? Or, the pain that you're having that you might not have if you lost weight, like focusing on like the goal piece of it rather than like the process, because I think the process can seem kind of overwhelming and uninteresting to people. It's hard to like, people like us who are like really into exercise, who love it. Like sometimes we don't understand, like, oh, people hate this. Like we have to sort of frame it in a way like, oh, right, you don't like this.
Like David Goggins.
Right. Yeah. It's like, some people actually fear it. Like, and then also sometimes breaking down, like, is it like you're too depressed, or like you're too scared, or you're too like uninterested, or you just haven't found an activity that you like? Cause I mean, there's a lot of things I don't like doing either. And I like exercising, but I would say like, that doesn't seem like fun either, so sometimes it's a matter of finding the right kind of thing for somebody.
I think it's really important for parents to get fit for their children, because I do think that, unfortunately, fortunately, however you look at it, your kids are going to become somewhat like you, and you look at different families, and, the parents who are fit tend to have fit kids, and parents who are unfit tend to have unfit kids. And, people will say that's genetics, and I'm not saying genetics play no role, but I think that it's more the habits that are being passed down as opposed to the genes. And, I know that sometimes can, be harsh and for people to hear, but I think it's a message that, we need to put out there. And the other part of that too, is that as physicians too, like people are like looking up to us. And, I like when I say that at the beginning of the show, or whenever we talked about, nutrition playing a role with regards to nutrition and our patients, you have to also, play the part yourself. You have to practice what you preach, and you have to be a role model to your patients. And I think that, that's another standard that should be raised, definitely by MDs and all healthcare professionals, really. And then also too for parents who are raising children, you definitely want to, be a role model for them. And I think that we have none of that in medicine at all. Like it doesn't get talked about. There's a few people like yourself, and we talked about a few other MDs that are kind of, coming together now, but it doesn't seem like something that, has been discussed at all in medicine in the past.
Yeah, I think in general, the culture of medicine is not necessarily to take care of yourself. Part of the training is, the training is can be brutal. So there's that stuff is all secondary, as far as taking care of yourself. But, beyond that, I think it's, we have to be examples for our patients. It's hard to advise people on healthy behaviors if you don't participate in those yourself. Also patients see that, right? I mean, I think, if they see someone giving them advice, they want to know that person believes it, so that's a part of it too. And like you said, I think a lot of physicians don't have the education for themselves personally about certain things like nutrition and exercise. So therefore they're not able to communicate it effectively to other people, because they don't necessarily know that stuff themselves. But yeah, it's like it's really hard to effectively take care of other people if you're not taking care of yourself. I mean, in my opinion, and how I find it's really hard, whether that's, as a professional or as a family member or whatever. It's like, if you can't prioritize your own well-being, it's going to be very hard for you to take care of other people and do that effectively. If you're not sleeping, if you're not exercising, if you're not eating well, that stuff's going to cause you to unravel. And then that just is a downward spiral.
And then you're a poor example for other people. And then you're also just in like poor energy, poor mood. And like, no one wants to be around that. So you're going to like infect other people,
Right. I mean, you can't be a healthcare practitioner and not practice healthcare yourself.
I agree. I do want to ask you about nutrition, and I know we have like less than 10 minutes left. So I've seen you with some pictures with Sean Baker. I think I mentioned that earlier.
Yeah.
So what is your diet right now, Amy, and what do you kind of promote mostly?
I mean, so I have met Sean Baker. He's a cool dude. So I mean, my personal, I do a lot of training. So, I mean, my first thing is protein prioritization. So I'm hitting at least a gram per pound a day. So I'm prioritizing that. And then adding in, I track macros somewhat strictly because of my training schedule. Because I'm usually hitting at least a CrossFit workout a day and sometimes an additional kind of Olympic weightlifting thing on other days. So, I expend a lot of energy and I have a fair amount of muscle mass, which requires a lot of energy. So I intake quite a bit of energy. But I prioritize protein, quality protein, with, different kinds of meat essentially. And then I'm filling it with veggies and having a small amount of carbs per before and after training or with my meals. I don't get too dogmatic about like, no carbs, no this, that. I try not to eliminate anything completely, but I do think that has a role for people who with metabolic syndrome and who have some pretty large metabolic derangements. I think then that does call for some of that. But personally, because of my training schedule and stuff, I'm just trying to adequately fuel. I mean, I work a fair amount with a lot of female athletes who are not doing that, and as a result have injuries and hormonal derangements and stuff like that.
So all your protein comes from meat? Like you don't use any whey protein, you don't use any like protein powders or protein bars, nothing?
Yeah, I will. So like usually in the morning I'll have like a little oatmeal with like protein powder in it and egg whites, and I mix that up and that's like my breakfast. And like after training session I'll have like a little whey protein in a shake or something. So yeah, I'll sprinkle that in just to help hit that number.
Yeah, that's why I do it too. I'd love to be able to get it all from meat, but I'm 200 pounds to get 200 grams of protein every single, like some days I can do it, but to get it 200 grams of protein every single day is just a little bit unrealistic when I'm working a lot. So
so protein bars or something.
Yeah, like my sources too. Like I don't have any affiliation with Quest or anything. It's usually the one that I get. And then I usually just use whey protein as well. And then so for your carbs, like if you are going to eat carbs, like is it like sourdough bread? Is it more like pasta? Is it more like butternut squash? Like what do you usually eat, and when do you usually eat it too?
Yeah, I mean, so for me, it's usually in the morning, some oatmeal, and then with my meals, like some rice maybe. On occasion, I'll have and on occasion I'll have some bread here and there.
How much grams of carbs per day, roughly?
Between like 90 and, depending on the day, like up to like 120 maybe.
Okay, so for higher training days, higher carbs?
Yeah, usually depending on my activities that day, whatever I'm doing.
Okay. And you sort of like spread them out, like you said, with each meal, like you don't stack them like before and after your workoughs necessarily?
Yeah, I'm not too strict about that. I mean, depending on like if I have an event or something that I'm doing, but like usually I'll just have, 3 meals a day with like a snack somewhere in there and a protein shake after I work out or something, so I don't do too much of that, like carb cycling stuff. Although I've done that in the past, but sometimes it's just like, it is what it is.
Okay. Cool.
Yeah.
Any, and some people don't like answering this question, but any supplements that you take or that you recommend that everyone should be taking or?
Yeah. I mean, so I usually have creatine in my protein
I take
shake.
creatine too.
Yeah. And there's a lot of good evidence about that for all kinds of things now, that's been coming out. Fish oil, vitamin D. Those are the main ones. Some magnesium at night. I'll take that. And that's usually like the basics, and depending on the day, sometimes I'll add in. That's pretty much it. I mean, I'm trying to think what else have I taken recently, but that's pretty much it. Yeah. So, those are like the basics. Sometimes some zinc, vitamin C, like around this time of year when it's cold and flu season.
Yeah.
But
do you have any specific mobility routines? Like there's some things I've gotten into lately, like the knees over toes guys got me doing the backwards on the treadmill on the incline. It seems to, provide a lot of good benefits, really, like low back, knees. And there's even, if you like do it at like 2.5 or 2.4, I think the study said, like miles an hour, you can even build a little bit of your VO2 max with it. But I've been doing a little bit of the bird dogs too from those Stuart McGill exercises. I learned those like 12 years ago or something crazy. And then I almost forget what they're called now, but just like towel pulls like behind your head. You can kind of see it, but for listening to audio, you can't. Yeah. Is there any like specific things that you do like all the time, every workout to prevent injuries?
Well, so yeah, there's a handful of things. I mean, I use a lot of like Kelly Starrett's stuff, Ready State. Has a lot of good protocols. He's a good dude also. He's like a good person, as well as getting a really smart guy about this stuff. Hip extension is something that's often kind of overlooked. We spend all our days in hip flexion sitting. And as a result, we're just all kind of like crunched down. So, things like hip extension, scapular kind of retraction, just practicing those a few times a day just to kind of get things, shoulders back. And I always tell patients shoulder blades back and down, kind of squeeze them together.
Do you get people to, I think they're called scapular wall slides, like to hold their arms against the wall and then kind of go up?
Yeah. So that's part of like the physical therapy protocol that I'll like prescribe when they do that kind of stuff. Yeah. Okay. I mean, I'll tell people like, just like if you're even at like in a chair at work, just kind of practicing like moving your shoulder blades back and down, and just, you can kind of do it as you're like working, do that a couple times a day. Yeah. And then, hip extension, like practicing being in hip extension, but then also just like stretching that out, is often, it helps with like back pain, hip pain, things like that. And then hip, like in general, like hip abduction exercises, which are, I can talk about butts all day, but that's kind of like gluteus strengthening is super important and often overlooked, which can also be this.
Yeah, I've had that before. Clamshells are the ones that I've done before to fix that.
Yeah, so I mean, that's part of it. I think a lot of it, like single leg activity. So like a lot of people, like, especially I see this in a lot of women, and I'll say like, can you stand on one leg for one? And a lot of people can't do that. And they say, I have really bad balance. And I'm like, well, unless you've had a stroke or have some kind of neurologic issue, unlikely, or an inner ear issue, unlikely to be a balance issue. It's actually a stability issue. And that's because your glutes are not holding you up. So you see people stand on one leg and their hips dip and their knees, if you ask them to squat in that position, their knees just cave right in. And it's because their glutes aren't holding their pelvis stable. It's not holding their femurs in good alignment. And as a result, they get knee pain, back pain, low back, hip pain. It's a whole butt pain. So hip abduction is super important, which is abduction. So the glute med is activated with hip abduction and extension, not just straight abduction. If it's just like moving your leg out to the side, you could cheat that with a bunch of muscles. But if you have to move your leg out to the side and then behind you to activate it.
Okay. Awesome. Yeah. Okay. Well, I think that's a great way to end it. Where can people learn more about you? Like, where can they learn more about the exercise that you're describing, and where can they find your Instagram handle and all that kind of stuff? Yeah.
So I'm at Amy West MD on Instagram and X. Going to start kind of ramping up the content shortly, because there's been some people asking for it. So I'm going to start ramping that up. Hopefully might be putting together a book. We'll see. But, working on some stuff. I'm also do a podcast with my friend, Matt Cowling, called Docs in the Box. So we put out episodes every so often about some interesting people that we meet. So you can look for that as well.
Awesome. Well, Amy, I learned a lot from you today. Thank you so much for sharing so much knowledge. I really, really appreciate it. And thank you so much, everyone, for listening. And as always, I'll be back again next week.